Good evening, everyone. Sorry if I sound a bit groggy. I think I have some URTI, so the nose, ears, everything sounds different. Over a period of next 10 minutes or so, what we'll try to do is just try to give you a flavor of what issues we face with small annulus and the issues which we face when we are looking at patient prosthetic mismatch. So we start off with actually understanding what a small annulus means. So by definition, it's annular area less than 400 or a perimeter less than 72. But a common definition which is used is if it's less than 23 of mean and 21 of mean and 23 diameter. Now this basically came up with the idea that initially if you had a surgical valve which was 21 or less which had to be placed, it was considered to be a small annulus. This is even before the TAVR era. Of course, now it has been refined significantly. Now the prevalence could be anywhere from 15 to 30%. But what is more important is in Asian population, it is much higher. And as all of you who are doing regular TAVR would understand, would agree with me, that most of the Indian population, especially females, we have this challenge of not only the small annulus, but everything small. The sinuses are small, the STJ is small, the femorals are small, and multiple challenges come up just when the patient has a small annulus. And 90% of women, most of the small annulus, 90% of them are actually women. What is the risk with small annuli? We know that they have a higher incidence of patient prosthetic mismatch. They can cause early degeneration of the prosthetic valve and can increase the incidence of permanent pacemakers and also produce significant annulus injury. Now this is the definition of a patient prosthetic mismatch. So we understood what a small annulus is and then what is a PPM. So this is well described now, depending upon the BMI. If it's above 0.85, you are safe. 0.65 to 85, it's borderline. Less than 0.65, it is a severe PPM in a patient who has a BMI of less than 30. But somebody who has more than 30 there, it is slightly different, where less than 0.55 is considered to be a severe PPM. Now, what are the concerns with patient prosthetic mismatch, a patient who has a patient prosthetic mismatch? We have evidence that it causes early structural degeneration, less LV mass regression, recurrent heart failure admissions. It can cause a decreased coronary perfusion pressure, and patients can come back with angina, reduced exercise tolerance, and increased all-cause mortality, which is described in patients with a severe PPM group. Now, there are certain general principles when we are dealing with a small annulus or the risk of patient prosthetic mismatch. What are the things which we know for sure? One, that TAVR has less incidence of PPM compared to SAVR. I think all of us who deal with our surgical colleagues, many times we are aghast at the size of the valves which they put. So this was the Notion 5-year registry where you can clearly see that both the effective orifice area as well as the gradients are much superior in TAVR valve compared to a surgical valve. The second thing we know is that patients who are put a self-expandable valve have a better effective orifice area as well as less gradients compared to patients who have a balloon expandable valve. So this is just to show you, I think we can't point it as such, but yeah, it won't come on the screen. But towards the left, if you see that is a balloon expandable valve, and towards the right, if you see it is a self-expandable valve. If you just look at the numbers, you'll realize that the difference comes to almost around 6 mm gradients. And if you look at the effective orifice area, it is much higher towards your right compared to the left. So we know that self-expandable valves fare better in both the parameters compared to balloon expandable valves. Now this is the Hahn chart, which I think all of us know, and you can see again the difference between a self-expandable and a balloon expandable. The balloon expandable has more red boxes, generally because the chances of developing PPM based on the body surface area, these are the predicted PPM, is much higher in a balloon expandable valve compared to self-expandable valve. The third thing which we know is that it's only the severe PPM which is associated with increased mortality. So this is the registry, the STS registry, and you can see that it's only the severe PPM which definitely correlates with increased mortality, whereas a none or up to moderate PPM might be okay. It, as such, doesn't translate into increased mortality. One word of caution here is the issue of age of the patient. So a person who is 80-year-old with restricted activity might be totally different compared to somebody because of certain comorbidities at the age of 60 or 65 is getting a TAVR done. In those patients, even a mild to moderate PPM, when they are exercising or have an athletic background, those patients, the PPM can become extremely significant and they can start getting symptomatic at a very early age. So this is again to re-emphasize the fact that even though we have shown you the effective orifice area, we have shown the difference in the valve areas as well as the gradients, that actually doesn't translate into mortality. Still the mortality, if you look in TAVR as well as SAVR, they are almost equivalent. The important aspect which is coming up now and is extremely important to understand is the issue that echo gradient should not be used to confirm PPM or advise redo procedure. Why? There is a significant discordance. Pre-TAVR is different compared to a post-TAVR or SAVR because velocity is not equivalent to gradient and echo gradients are not equivalent to poor outcomes. So this is referred to as the discordance and concordance. Pre-TAVR, there is a significant concordance between echo and cath, whereas post-TAVR, there is a significant discordance. Why does it occur? Because what we are dealing with is the simplified Bernoulli's equation. If you see this chart, it's such a complex equation which we need to do. So we have just simplified it to 4V square. So the only way that you will have a zero gradient, on cath you might have a zero gradient, but the only way that you will have a zero gradient on echo is when there is no output across the valve. That means the patient is dead or the heart has stopped. So that is, it's not physiological. That's the reason why they don't correlate with each other. Now, there could be different reasons why the velocity can increase. So these are the different reasons which can actually produce an increased gradient on an echocardiogram. Now, this is an elegant slide just to emphasize to our echocardiographers that these are all the parameters which need to be looked into. Just 5 days back, we had a patient who had a hemoglobin of 6 with a 1 year post-SAVR who was told to be having a significant PPM when actually there was no PPM. It was just because of the anemia that the patient was having exaggerated gradients. And when a DVI was calculated, it was actually normal. So this probably should be there in every echo laboratory to make sure that we don't commit mistakes. So how do we proceed if there is an elevated gradient? So the definition of elevated gradient, baseline gradient is important to compare. First you look at the CT, see if there is evidence of any halt or valve thrombosis, then give anticoagulation for 4 weeks and reassess. If it's not there, then see if there is concordance, that's you do a cath study. If it's concordance, that means cath gradient also increased, this patient requires reintervention. Whereas if it's a discordance, then you can safely just monitor the patient, you need not do anything. What are the predictors? How to optimize? Oversize by around 15%, do a pre-dilatation and a good post-dilatation, and supraannular design always is helpful. These are the different valves, the self-expanding valves. Almost they fare equivalent. Probably the Evolute Pro is slightly superior to others, but otherwise no major differences. So I'll just end with a case example. This was a 75-year-old lady who had significant angina, breathlessness, severe aortic stenosis, significant gradients, normal coronaries. And you can see all the parameters. They are so small. Everything is small, including the femorals. So the plan was to go ahead with self-expanding valve, of course, 23, and that itself oversized this thing by around 20%, which was slightly higher for a bicuspid valve. So a normal routine procedure, important to do a pre-dilatation. These were the initial gradients, a pre-dilatation done. Then we could get away with a good result in the end with practically zero gradient and no PVL. So follow-up, she's doing quite well. I think this is about a year and a half back. So summarizing, ladies and gentlemen, it's important that we identify small annulus and we know how to deal with it. It is common in our population. SCV is better. The discordance between echo and cath we need to understand. Baseline echo gradients are important to compare. CT to rule out thrombosis should be the first step when the gradients go up. Cath study to confirm before we intervene. And the ongoing SMART trial, of course, will give us more information. Thank you.